This conference will now be recorded.
Okay. And it will be posted to YouTube this afternoon, and I will send the link out to everyone in attendance on the meeting. So with me today in the room are my colleagues Katie and Taylor from Department of Social and Health Services Research and Data Analysis Division. So the budget proviso instructs Commerce to link up with RDA to do an evaluation of this program, and I'm going to turn them loose to introduce themselves at this time.
Hello, my name is Taylor Danielson. I am a research manager at Research and Data Analysis, and I am working on research related to homelessness in the state of Washington, as well as various activities under the 1115 Medicaid Transformation Project. And to my right is...
Hi, this is Katie Bittinger. I'm also a research manager with DSHS RDA, and I work on Medicaid and healthcare-related projects. I've worked a lot on Initiative 1 of the Medicaid Transformation, as well as some of the other initiatives. I've worked with the ACHs for quite some time.
Great. Thanks, Katie and Taylor, for being here. The three of us, in concert with our friends in Chicago, are going to try to answer your questions after we cut the Chicago folks loose to give us a presentation on their program design. And before we get to that, I just want to do a roll call to see who's on the phone with us. So do we have anybody from the Spokane ACH Better Health Together?
Hi, this is Katie Coker in Spokane.
Hi, Katie. Welcome. Thank you. Anybody from Cascade Pacific Action Alliance?
Good afternoon. This is Jean Clark.
Good afternoon, Jean. Thanks for joining. How about Greater Columbia? I think we saw notice that you were on the phone. Is that true?
Hi, this is Lauren with Greater Columbia. I am calling on behalf of Carol Moser. She's hoping to call in here at 2, but had a conflicting meeting, so I will be standing in for her.
Perfect. Thank you so much for joining us. King County, Healthy or Here, are you on the phone with us?
Yes.
Elise
I have a couple partners on the phone as well. Go ahead, Elise.
Sounds like a couple of
from Healthier Here on the board of Healthier Here.
Thank you. North Central, Accountable Community of Health. Anybody on the phone? Okay. How about North Sound ACH? Okay, anybody from Olympic Community of Health? Anybody from Pierce County ACH or Elevate Health?
Yes, Melissa Ragianti and Angie Chepto.
Welcome, thanks for attending. How about Southwest ACH? Okay, great.
Hey, good afternoon. I'm sorry, this is Mark. I'm not sure where to jump in on this. My name's Mark Waka with Providence Health and Services, and we're in a variety of these ACHs, and so I just wanted to, I'm not sure which one you wanted to be with, which one I'd jump in on, so I just want to let you know at the end.
Are you representing Southwest specifically?
No.
Okay.
But I didn't hear them jump on either, so I saw the pause, so I thought I'd jump in.
Okay, great. Thanks for joining us. So, also on the phone in Chicago with us are Ben Darby, the Housing Supportive Services Specialist at the Center for Housing and Health in Chicago, and also Stephen Brown, Director of Preventative Emergency Medicine, University of Illinois Hospital and Health Sciences System. Welcome to both of you from Chicago. And I want to turn it over to the two of you to give the team here in Washington State introductions of yourselves and a brief overview of your program. And then after that, I will present some questions to you that I've already received from some of our potential applicants. And after you get a chance to dialogue over some of those questions, then we'll do an open question and answer session, and hopefully that will go really smoothly. So, Chicago, take it away.
So good afternoon. This is Stephen Brown. I'm the Director of Preventive Emergency Medicine at the University of Illinois Health Sciences System, and with me is Ben Darby from the Center for Housing and Health. I am the project director from I'll refer to University of Illinois as UI Health. I'm the project director for this program that started as a pilot in 2015. I was previously a social worker in the ER at University of Chicago and a child protective services worker there, and then transitioned to the University of Illinois in 2011. My area of specialization is healthcare superutilizers, and my research is around getting underneath what drives cost and utilization, and why do some individuals use excessive amounts of healthcare resources. And hope to be able to demonstrate to you today that the chronically homeless, the focus of this pilot and program, was and how we were able to identify those individuals and manage their care. I don't know if you're, Jim, if you're going to share the screen. Mine's available to that at any time. But Ben, go ahead. Ben, go ahead with your introduction.
And yeah, Stephen, I have given you presentation status, so you should be able to share your screen.
All right, I'm going to do there. And let me know if you can see it.
You go first.
Yes, we can, thanks.
Okay, great. Go ahead, Ben.
Okay, I'm Ben Darby. I'm the Better Health Through Housing Coordinator at the Center for Housing and Health. I was the administrator of the program. Before I worked at the Center for Housing and Health, I worked for the Resurrection Project, which is a nonprofit housing developer in Chicago. And before that, I was a case manager at Boston Healthcare for the Homeless program.
Great, thanks, Ben. And I guess working for Boston Healthcare for the Homeless, that makes you a rock star too. If you know anything about Boston Healthcare for the Homeless, they do incredible work under the leadership of Jim O'Connell there. So we're going to describe our program here today, its genesis, what we've learned along the way, some of the outcomes, and where we're going with it. This started in 2015 between a conversation with the Center for Housing and Health, which is a subsidiary of the AIDS Foundation here in Chicago, and UI Health. One of our assistant vice chancellors was also on the board of the Center for the Housing and Health, and CHH had come into subsidy from HUD, looking to create a healthcare to housing pilot, and so they approached us. On our side, we're a state institution, one of two public hospitals here in the state of Illinois, and we have a health equity mission. I think over 60% of our patient population is on some form of government assistance. And our unique mission is to provide a tertiary care hospital for the citizens of the state of Illinois. And so looking to promote a health equity and access for our patients, plus the idea that we were thinking about how we could implement baby steps into population health. We took on the responsibility for this program. We were the first hospital here in the Chicago region to stand up a Better Health Through Housing program. And we did operate solo for about 7 or 8 months. There are now, I think it's 4 or 5 other hospitals that have very similar programs here in the region. The second to come on board was Swedish Covenant Safety Net Hospital on the northwest side of Chicago, then Rush University Medical Center, which is located about 3 blocks from where we sit here at UI Health in the Illinois Medical District, Northwestern University Hospital in the Gold Coast region of the city, and Cook County Health, which is in the Illinois Medical District, located about 2 blocks west of where we are. So there seems to be growing interest here for healthcare organizations to jump into the Better Health Through Housing model. We started with a $250,000 allocation from the hospitals, from our hospital's leadership. Some of that was philanthropic funds, some of it was general operating funds. We operate now exclusively on general operating funds. We took our first patient in November of 2015, and what you may hear referred to as our first cohort of 26 individuals that were referred into permanent supportive housing. Some of them touched housing briefly. Some are still successfully domiciled, and we'll talk a little bit more about that. So with that as a background, then I'll turn over to Ben to talk a little bit about how Chicago's homeless compares to other U.S. cities, so you can get a relative comparison to what's happening in Washington State, and especially in King County and Seattle.
Yeah. So in Chicago, if you count the city and Cook County, there are about 8,115 people who are experiencing homelessness, which would be fifth. I think Seattle and King County is at about 11,600. And then Chicago, just the city, is 5,657, which would be 11th of the major cities. So that is a little picture of how many people are experiencing homelessness within Chicago and Cook County. And then we have a slide with the three basic kinds of homelessness: transitional, episodic, and chronic. And in this project, we focus on the chronically homeless, which are mostly individuals who have been homeless for a year or more. There's a HUD definition for chronically homeless, which is being continuously homeless for a year or more, or you can have four instances of homelessness in the last 3 years, but it has to add up to 12 months. And these people tend to be older with significant mental illness, substance use, and chronic health conditions. And that is the population that we focus on in this project. And so, sorry, Steve, were you going to say something?
No. Just one other thing as a point of comparison. So between the city and the county, that represents 42% of the state's population, so a significant majority of the state's population. Right. Go ahead, Ben.
Right. And so just taking you through the logistics of the project, UI Health refers clients to us, clients to us that meet their definition of high utilization, which I think right now is three ED visits in the last 6 months. Is that right, Steve?
I'm sorry, I got distracted. What was the question?
The definition of high utilization that you guys use when referring clients.
So it's a minimum of 4 visits in the previous 12 months, but we tend to concentrate on anybody that's had 8 or more visits in the previous 12 months.
Okay, gotcha. And so they refer...
I'm going to apologize. I think this slide I think these things automatically advance every 30 seconds, and so I may be flipping between slides. So go ahead.
So when UI Health, they have a panel called the Chronically Homeless Referral Panel, where they make decisions about who to refer to the program. And Steve, do you want to talk a little bit about the CHIRP panel?
Sure. You want me to flip to the next slide?
Sure. Yeah.
Okay. I just want a comment of this from my perspective before we advance the slide. This is a really great model for healthcare to engage with, because it means that we have access to a deep network of housing. And oftentimes hospitals will contract with a single agency, and that agency is not going to have the depth nor the variety of housing necessary to retain people into housing. The great thing about what's been presented in this model is it gives people choice, just like any other renter, instead of being handed something with expected gratitude. This gives our clients and patients the right to determine for self-determination, because there's choice available across the city. So as you can see in this slide, there's 4,000 scattered site units, and we count on a vacancy rate of somewhere between 125 to 150 vacancies per month. The single room occupancy hotels gives us the ability then to accommodate people almost immediately, within a couple of days to up to a week, to be able to get them off the street rapidly. And then it's just the model that was handed to us is really, really advanced and something that works very well for us and the other hospitals in this region. So our process then, and I'll take the first couple of slides, first couple of columns here, and Ben will pick it up. So we use a list of all of our frequent visitors, starting with the ones that have the highest utilization of healthcare services. So currently we have one individual that has had 105 visits in the previous 12 months. And then through a variety of different informatics ways, looking at ICD-10, the most automated way to do this is that we look at the patients, what they list as their primary residence, because oftentimes they'll list the address of a crisis shelter, a hospital, or a church. We have found now to date about 3,500 individuals that have listed those three types of places as their primary address. And through other means, including chart audits, which tend to be very labor intensive, we have a combined total of about 5,300 individuals that we've identified now. So we do start with identification. We provide it to our ED staff and our psych unit, and as it turns out, our oncology unit too, because there's very high rates of head and neck cancers in this population. And then we ask people to, based on the criteria for the program, to refer people into the Chronically Homeless Referral Panel, or the CHIRP panel. We decided to go with this format because often the decisions to be made on whether to refer or not to refer somebody into the program can be both medically and ethically complicated. We often have to make very difficult decisions on who goes and who can't. And often, because the criteria is HUD homelessness, oftentimes people will miss that criteria by weeks, sometimes a few months, and then we have to defer them so they come back later. But generally what we do is we get together every month and we refer 4 or 5 case presentations are reviewed. Representatives, including Ben, are there from the Center for Housing and Health to make sure that the patients meet the criteria of the program. We also invite the outreach worker who will be engaging with these people and often has great insight into whether or not somebody might be appropriate for it. And I will say one of the things that were you going to say something, Ben?
No, you go first.
Yeah. One of the things we learned later on in this program after our first cohort is we implemented within this, we use a tool now called the LOCUS, Levels of Care Utilization System. You can find all kinds of PDFs online if you just do a Google search for it. And it has been used traditionally in the world of assertive community treatment to see what kind of level of supports and housing is necessary for somebody with a severe mental illness. It's generally used by assertive community treatment providers. We implemented it here because we often found, and we'll talk about this later, most of the housing we had was scattered site with housing support case managers. And so we didn't have much project-based housing in this with 24/7 support. And because it was mostly scattered site, we had to put in a locus, and we put in a threshold of 22. We will consider scores that are somewhat higher, up to 24 sometimes, but we need to assure that they have the proper level of community level support in this. So that is another one of the criteria that we've put in place now. We hope to be able to add more project-based housing. There's a lot going on in Chicago, but as the program stands to date, it's primarily scattered site housing. So go ahead, Ben.
Yeah, and so once the referrals are made to the Center for Housing and Health, we reach out to outreach, and we also do this at the CHIRP, and reach out to outreach, and then they work with the ED social workers to locate. The social workers usually, provide background, phone numbers, and things like that to the outreach workers, and so then they go out and locate the patients, do a basic screener to see if they meet the chronic homelessness definition, HUD's chronic homelessness definition, and then they collect the documents showing chronic homelessness. And so once we get the documents showing chronic homelessness at the center, we can enroll them or accept them into the program, and then we refer them to a housing provider. And this, going back to the last slide, we have a network of 27 supportive housing agencies that we work with in various parts of the city that we can refer those clients to. And so, yeah, like Steve was saying, that is a great benefit because they can access different networks of housing all over the city. And so then those case managers, the housing provider they're matched with, they get a case manager, and then those case managers help them locate housing. We try to do this within 3 months of enrollment into the program. Sometimes, depending on a client's background and circumstances, it can take much longer, but we aim for 3 months. And then after, I forgot to mention Bridge. Before somebody is placed, or while they're working with their case manager to find permanent supportive housing, they have the option of using a Bridge unit, which is, we have 3 single-room occupancy hotels in Chicago that we use for Bridge. And so somebody will go there, stay there while they're looking for housing, and then once they move into permanent supportive housing, they'll move out of that Bridge unit. And then once somebody is placed in permanent supportive housing, we have monthly system integration team meetings, which brings the hospital and the center and the case managers at the specific agencies together to do case consultation and troubleshoot. And so that's been really a really great part of the program, in that housing case managers have had access to a lot of information from the ED social workers and people who participate in that SIT meeting that they wouldn't otherwise have. On their PSH caseloads, only some of the clients are Better Health Through Housing clients, and they have much more information about those clients than they do about some of their other clients, because they have a direct contact at the hospital. And so there are ongoing SIT meetings throughout, sometimes biweekly, sometimes monthly, depending on need. If clients are mostly doing well, then we can do monthly, and if there is a lot to talk about, then we do biweekly. So yeah, that's the basic program. Steve, do you want to talk about?
Yeah, and so one other point there is, we don't just charge our patients from the emergency department. We found that didn't work. When we started this was a pilot, and it was a learning model. And we quickly learned that trying to have the outreach worker come to the ED was going to be a mismatch, primarily because most of these chronically homeless individuals come anywhere from 7 p.m. to 3 a.m. They generally come in overnight, and so there's a time mismatch. It's also a time when we're down on staffing, and when the ED is very, very busy. And so we count on 2 things: the fact that they're going to come back to us, 1, and 2, we now ask where they hang out, and we found that most of these individuals seem to reside within a 4 to 6 block radius, and so they're generally easy to locate within a few days to a week. So we don't just charge a patient directly into the program. I just want to make that point. So what were our outcomes? So we measure everything in what we call our first cohort, which was 26 individuals, and then to date, and that ran from November 2015 to January 2017. That was when the last patient in that first cohort was placed. We now have placed a total of 59 individuals since the beginning of the program. In the first cohort, we had a very high rate of psychiatric illness and mortality. We'll go back here. And so the retention rate was lower, as 47%. Since we've implemented the locus, it's gone up to 70%. We also think that's directly related to the lower mortality rate, because the folks that we're seeing the people we're putting into housing are not as severely mentally ill. Again, this does a bit of a dilemma for us, because we would like to be able to take all comers, and there are conversations ongoing right now about a tiered support we'll talk about later in the program. I think I got everything on that one, so I'm going to move on. should we assume that everyone knows what Housing First is? If not, I'll just give you a brief overview. It doesn't require any kind of treatment first before they go into housing. Most of what we have here is scattered site housing. It's one bedroom independent housing, not a group setting. It's a third of the income no matter what they do. If they don't have any income, that's okay. And it comes with a supportive case manager. And I must emphasize they have no training in healthcare or in psychiatric illness. These are housing support case managers. We've had some pretty good outcomes even with them because they do help our patients get to their medical appointments and learn basic things like how to pay rent, and help them with getting furnishings for their apartment and troubleshoot things. Enough on that. So these are the chronic medical, psychiatric, and substance abuse conditions that we saw. I just want to emphasize this is 70% African American in our first cohort, and you can see there was a pretty wide age range, all the way down to 26 or all the way up to 68. But we had some very high rates of mental illness, especially severe mental illness, substance abuse disorders. Metastatic cancer was 1 in 5. Again, we think because we had such an acute cohort. And overall, there were very high rates of infectious diseases and heart disease. So what did we learn? Homelessness is a dangerous health condition. So 34% mortality rate in the first, that should be 21% in the second. And what we're learning is what we think is there's going to be some intersection with some policy issues. Our crisis shelters are way too large, and they have no capacity for handling people having a psychiatric illness. And so we believe we have a very high rate of unsheltered, chronically homeless in our emergency department. We're located about a mile west of the Chicago Loop, which is the number one hotspot of chronically homeless individuals in the city. We're in the west side, the near west side, which is about the third or fourth largest congregation of chronically homeless. Lesson number 2, the homeless are invisible in healthcare, and for those healthcare organizations, I think it's very important to be able to do the data mining to identify these individuals, because it's just not documented very well in healthcare. When I started this program, we had 48 individuals that we identified. I'm sorry, this is leafing through for me, so apologize for this. And we now have about 5,400 individuals since 2010. Currently, in any given fiscal year, we estimate somewhere between 1,300 to 1,500 current patients. We haven't been able to type them at all. We can identify some of the chronically homeless, but we haven't been able to do much typing beyond that. Lesson number 3, the chronically homeless have exorbitant healthcare costs and utilization. So we had healthcare costs that were somewhere between 1.9 to 160 times higher than our average patient costs. Now, I want to emphasize this is just cost. It's not what was the profit or loss on these individuals. We are currently conducting an evaluation which would be available in about a month that would show profit and loss on this cohort individually and collectively, and we'll publish that when it's available. But to give you an idea of some of the cost shifting that happens, and this classic idea of wrong pockets problems, it sounds like the state of Washington is taking some really impressive steps to be able to eliminate this wrong pockets problem. The average cost, if you can see that most of the cost now is shifted into healthcare. And so you'll see an ambulance ride being $800, all the way up to a per diem of $2,600 for an inpatient hospitalization. And we know most lengths of stays for these individuals is about 3 days. So the average compensation for an inpatient hospitalization is somewhere between $7,500 and $10,000. So these individuals, some of these super utilizers are very expensive. And this is a bit tongue-in-cheek, but by contrast, another bed, we have the most expensive beds in healthcare, or in the country. By comparison, it's about $625 an evening. And so we've often thought it'd be cheaper just to put them up at a 4-star hotel. But you can see that this is to emphasize that we have a classic wrong pockets problem that shifts the cost to some of the most expensive beds. And then going forward, all solutions should be multi-sector solutions. We have a lot of collective impact projects happening here in the city of Chicago. We've had a lot of engagement with the criminal justice system, with first responders, including police and fire. As it turns out, one of the number one hotspots for 911 calls here is Pacific Garden Mission. It's the largest crisis shelter with a capacity of somewhere between 600 to 800 beds. And the fire department receives about 1,200 dispatches to that location annually. And so we're in conversation as to see if we could open healthcare facility either nearby or within that facility to provide better healthcare for those individuals. And this is the reason why we need to work together. This is a recent profile of patients identified that had a severe mental illness, and you can see the comorbidity of the top 100 with substance abuse disorders. And then I had spoken previously about their chronic medical conditions, but you can see that there's a significant amount of overlap between substance use and severe mental illness. And so as providers, we need to be able to think about how do we treat all three equally, not just one in a sequence, but everyone simultaneously here. And so this is driving some of the conversations with Ben and his organization. In our program here, we had only scattered site housing, and we take patients up to a 22. But this is the level of conversation that we're having. There were several patients that we saw in our CHIRP panel that had scores well in excess of 22. And if we knew there had been embedded ACT into this model, we would have felt more comfortable referring people with moderate to severe mental illness into the program, but it just wasn't available, and so we didn't feel comfortable referring those individuals. For many of the individuals that have the most severe mental illness, project or cluster base is something that we're going to need to think about in our model. And Ben, did you want to say anything in this slide then?
I mean, I think all I would say is that we've had a couple of clients who have been above the 22 score, not just in the UI Health project, but also in other hospital projects. And, depending on when the locus score is administered, it could be much higher or much lower if somebody is on their meds, if somebody is off their meds, and things like that. And so we've had some successes with some clients that have been, this one individual in another project who scored, I think it was a 25 or 26, but it was more kind of by chance, right? So he was living in his unit and he went off of his meds and he would refuse to engage with anyone to the point where he was about to be discharged from the program, because to have these kinds of subsidies, you have to engage with your case manager a certain number of times within every 3 months. So he was about to be discharged, and then kind of fortuitously he got admitted into a hospital, and then got transferred to the psych ward, and then got put on a long-acting injectable, and now he's functioning well within his scattered site unit. And I'm guessing that if he took the locus today, he'd be a 22 or below. And so, I guess that was just kind of an example of it's very hard with individuals who have such severe mental illness.
We saw many people with severe mental illness who were stable on their meds, and then they stopped taking them, they decompensated, and then they would just leave their unit and not come back to it. So this is part of this learning collaborative, building a model between two different sectors here. So it's some great conversations going on. And then finally, we're going to talk about what Ben's going to talk about, the collective impact of the flexible housing pool. This is something we're doing here that's modeled off what's going on in LA. Yeah,
and so the flexible housing pool is a new project that started it started this past year, that brings and braids different types of funding together. And so the initial investment was by the city of Chicago. And what is great about the flexible housing pool is that the subsidy is not a HUD subsidy. So people do not have to meet that kind of strict chronic homelessness definition, but instead the referrals come from Cook County Health, and they are frequent utilizers of the criminal justice system and the hospital system. And so those people who are housed are not, it removes this barrier of having to collect chronic homelessness documentation, these kinds of things that hold up identifying somebody who's a frequent user and who is kind of in the bucket of chronically homelessness, but does not necessarily meet the HUD definition is very specific, and housing them quickly and effectively. And the biggest, like Steve was saying, the most kind of effective part of this model is that it's a collective impact model. So multiple sectors, the city can invest, and then hospitals can invest, and private philanthropy can invest in one pool that then provides the subsidies to participants.
Great. Thanks, Ben. And so with that would conclude our presentation, and we're happy to take questions.
Great. Stephen and Ben, thank you so much. That was a lot of information. To our attendees on the phone joining the conference call, I want to ask you to, in an attempt to kind of manage the question asking, I want to ask you to write questions you have into the chat dialog box over the next couple of minutes. And while you do that, I've received a couple of questions in advance that I want to pose to Stephen and Ben. And I'll just say now that my colleagues Katie and Taylor here in the room with me may kind of enter as we see fit and necessary to modify any kind of a response that we get from Stephen and Ben on some of these questions. So we'll take this, we'll get it going. Go ahead and write your questions into the chat box. And Stephen and Ben, first question for you is, did you have formal agreements with your partners already in place prior to the program, or were they developed as a part of the program startup?
So, Steve, I'll just take a...
Yeah.
So in terms of the housing providers that we utilize to provide PSH to the clients, the center ran HUD subsidy programs before, so we had relationships with a number of the housing providers that ended up being involved in BHH. But those were different programs and different agreements. But so when this idea kind of came together, we could pull from that network, and we have separate subcontracts with each housing provider specifically for BHH. But we also had agreements for other programs before with a lot of these housing providers, which made it, that's, I think, part of the model, that the fact that we had relationships before made it easier to get all the housing providers involved.
And then from our perspective, we sole sourced it to Center for Housing and Health because obviously there's no kind of model like this. It took us a little longer as a state institution to come up with the contract language for that. But then we also our lawyers were very comfortable signing a business associates agreement so that we could minimally necessary, but very necessary to transmit medical information about our patients, so that the case managers could assist patients getting to some of their standing medical appointments. They were also very, very comfortable, even though there were only memorandums of understanding with the 27 supportive housing agencies. They were comfortable being able to share PHI with those supportive housing agencies because our lawyers recognize the impact on health. And although HIPAA was written back in the day for provider-to-provider healthcare conversations, they felt that there was such a impact on health through this program that they were comfortable allowing to have healthcare information conveyed to the supportive case managers.
Yeah, thanks. That actually addresses, I'm glad you mentioned HIPAA. That addresses one of the questions we got about how to navigate those regulations. Did you find that either the hospitals or the people to whom the by name lists were provided expressed any reluctance to deal with that PIH?
You mean the healthcare providers?
Yeah.
Well, we set some guidelines around that so that, it was what was necessary to get someone to their appointment, oftentimes, that they were going to see an endocrinologist for their diabetes, and that the appointment was going to be this. If there was things that we could help that would explain some context of why somebody might have some difficulty ambulating, we would express those things too. And so we did stick to the guidelines of minimally necessary in that, but I don't think we ever ran into any reluctance disclosing PHI.
Okay. I think this is probably for Ben, did you utilize your continuum of care partners in Chicago and Cook County for resources for housing?
Yeah, so a lot of the housing providers are members of the continuum of care.
Okay.
So yes.
Okay, so I want to start taking questions from the field. Can you talk to us about who administers the locus and where and how often? And maybe a little more detail just about the locus in general for those not in the know.
And sure, if I can send you a copy at the conclusion of this so that you can distribute it to folks on the call. And there is a scoring guide that comes along with it. So generally that was administered by, it was primarily social workers. Oftentimes it was a social worker that was presenting a case, although in a couple of circumstances we had an ED attending and a psychiatrist from the floor present cases to us. Those were the two, most, 80-90% were social workers, and then there were a couple of physicians that presented them.
And I think I heard you say at the outset of your presentation that you make a referral monthly of, I don't have it in front of me right now, I think you said 5 to 10 people per month, 5 to 7 people per month?
So generally we'll meet once a month, and it's with the case presentation format, we have enough for about four case presentations. I think at max we've done 6 at one, but it's on average around 4.
Okay.
And to give you an idea then the efficiency of this, when we first started the program, we took our first patient in November of 2015. We didn't refer the last one out until January 2017, as we were kind of learning it. In this last fiscal year, we started in September, and by December we had filled the panel. So we had a $250,000 allocation, and what we do then is we use a spreadsheet or what we call projected spend. We pay the Center for Housing and Health $1,000 per member per month, and then we track those expenses on the forecast that most individuals will stay 12 months. That gives us enough money to refer anywhere from like 18 to 22 individuals. This year, our allocation is $300,000, and so we should be able to refer 25. But that's not a hard and fast number, because in our first cohort, for example, we had one lady that was in housing for a month and then passed away. Or one gentleman that was in housing for 3 months and then violated the terms of his parole and went back to prison. So the best way that we can track what we do then is projected spend, and then that individual, if they're discharged from the program, the remaining money that was initially targeted for that individual is freed up for another referral.
Gotcha. Thank you. Next question. What services are provided to your clients while they're housed? Are there on-site medical or behavioral health or personal care services to assist with activities of daily living?
It mostly depends. I mean, usually not, because most people are placed in scattered site housing.
Right.
Some people are placed in project-based if there's an opening. It depends on what housing provider they're placed with, and then if that housing provider can find project-based housing in the city. But most are scattered site, and so the services provided are the normal services by a permanent supportive housing case manager, which would be, assistance getting to medical appointments, assistance with transportation, assistance with benefits, applying for insurance or SSI or SSDI, budgeting, assistance with basic, living needs and things like that. Referrals.
Right. And from our end, we are considering bundling some of these things. So we had, and it's purely circumstantial, we had an individual that was brought in by our Chicago street medicine team. It's a team of residents and students, medical students, that navigated an individual, an unsheltered individual with an opioid use disorder that had a very bad abscess in his arm. In his legs. He was navigated into us. We got him on Suboxone, and we were able to transition him to an outpatient setting where he got medication-assisted treatment, or MET, and he did very well. And then coincidentally, then he was referred into the program and now is successfully housed and still in treatment. What we're looking at on the healthcare side is, can we do that medication, more coupling together of these services. And then the other thing too is that we're looking at is scaling assisted outpatient treatment for those folks that have refractory and severe mental illness that are incapable of caring for themselves. So we hope to be able to perhaps bundle some of that together too, so that somebody that's that's under a mandatory medication order then is also once they've stabilized and perhaps they've gained some of their insight back, would be offered housing. We haven't done that, but it's something that we're in exploratory stages of.
Great, thank you. In the non-flexible housing pool program, where does the housing subsidy come from? Is it housing choice vouchers or project-based subsidies?
It's a PSH HUD subsidy.
PSH HUD subsidy. Okay, thanks. Next question. It seems like the success of this program relies on the availability of housing stock. Can you talk about what the stock looks like in your location? And are you getting units dedicated for this program from landlords?
It depends on, so each permanent supportive housing agency kind of has different, or housing provider has different, some, master lease certain units, some have buildings of their own. Because of the model and we work with 26 different housing agencies, it kind of depends upon each agency what is available to them, and what kind of relationships they've established with landlords. In terms of the overall housing stock question about Chicago,
how about vacancy rate?
Say that again?
How about vacancy rate in Chicago?
I'm not sure what the vacancy rate is. Steve, do you know?
No, but we did run into one of the unintended consequences is, because we're using housing first, the vacancy rate tended to be lower than originally forecast. And so what we thought would be somewhere between 30 to 45 days to be able to house someone, sometimes went to 60. It was more than we anticipated. So that's the only thing I can add from that standpoint. Other than that, I don't know what the vacancy rates are here.
I just, maybe in terms of my experience so far has been that housing people, we've been able to find units, but usually the problem is something in a credit score or a background check or something like that. Like the case managers have always been able, in my experience, to find units definitely on the south and west sides of the city, less so on the north side. The north is more populous and it's also wealthier.
And do you have any kind of landlord incentives for those instances where there's a criminal record?
Yeah. So some of the things we learned from LA County and LA City and their flexible housing subsidy pool and is being put into place here is that landlords sometimes like these programs because it's guaranteed income. There is a source of remediation because oftentimes there will be issues like someone inviting people that shouldn't be in the unit there, or some damage to the unit. So there's a single contact for remediation of ongoing issues like that. And then the other thing too is that it really depends on the landlord. Many are much more tolerant than others, and many might even have relatives or friends that have engagement with the criminal justice system, and they seem to be more tolerant. It runs the gamut. And part of the responsibility of the third-party administrator, the flexible housing pool, and what the Center for Housing and Health does is to build relationships and understanding those landlords and the type of populations that they're willing to accept. So it's you can't say it's the same for everyone. It's different in every landlord, but it's part of the relationship building with the landlords.
One thing I would just add real quickly is that with the flexible housing pool, the Center for Housing and Health is directly building relationships with landlords. But for the Better Health Through Housing program, because we have subcontractors who are housing providers, those housing providers are actually doing the housing location, and they have their own housing locators and people at those agencies who have built relationships with landlords. So with BHH, I'm not directly building relationships with landlords, but the housing providers we contract with are.
Great, thank you. Next question. In regards to the data sharing, did the case managers have access to medical health records or submit paper files? In other words, how did they physically share the PHI?
So generally at the SIT meetings every month, we have a program social worker. It's about her responsibility is about 0.25 FTE. And she would, for each of the patients that were going to be discussed at the SIT meeting, she would give a list of appointments for each one of those individuals. Sometimes what we started doing on a proactive basis then is we started giving didactics from from different physicians and nurses on common chronic diseases so that the case managers would have some insight into what they were seeing in their patients. And not that this was a responsibility, but more for their own insight and management of those individuals, began to understand the chronic disease process and the needs of those individuals, and would be able to help them then navigate the health system.
And this is Katie from RDA. I just want to chime in on the end here. And I know this is an important and sensitive topic, thinking about data sharing and while protecting client rights and information, and the need to balance that with the ability to people have that minimally necessary information. So this is something that once an apparently successful bidder has been announced, and we can work more in depth with that organization and the team that they'll have to identify the best process for sharing minimally necessary information.
Great. Thanks, Katie.
Mm-hmm.
The project in Chicago is taking place in a densely populated urban center. Do you see this program being equally successful in a rural area?
Interesting question. My only initial thought would be that maybe it'd be easier the vacancy rate might be higher and the cost for a unit might be lower. So maybe it would be easier to initially house people. The travel, depending on how rural it is, the travel might be an issue with how many, if case managers are able to get out to the. I'm not sure. Steve, do you have any thoughts?
Yeah, there have been some programs that are started in mid-level cities. There's one that's been replicated at OSF St. Francis in Peoria, which is a fairly urban area, but it's not one of the larger cities. I have heard of programs in Columbus, Ohio. And, I could get you a list. I can't think of the other ones off the top of my head, but there are other programs that have been spun up in, St. Louis. I think there's some activity going on in a pure rural area. I've never really given it thought how we could implement something like that there. I think the methodology would work. Start with the most frequent visitors and identify housing providers within that region. I could, it's something if need be, we could talk through a little bit more.
Great. If you would not mind sharing that list of projects that have sprung up since yours has, that would be really helpful, and I would pass that along to our attendees on the meeting. Thank you.
Okay, great.
Next question. Can you talk more detail about what the $1,000 per member per month covers? Housing costs, medical costs, case management services, what does that $1,000 go to?
So it's actually left up to the housing provider. UI Health pays the center $1,000, and then we have an administrative fee, and then we pay 85% of that $1,000 to the housing provider for the month that they're housed. But because it's a HUD subsidy, the rent and the housing is already paid for, and so that money can be used by the housing provider for extra services, staff time, whatever they need in terms of to implement the program.
So I think I interpret that the fact that there's another funding stream at play that's actually covering the rental subsidy is a key component.
Yeah, and covering the rental subsidy and the case manager. So
right.
Yeah.
Okay. Do you know the average length of time patients stayed in the bridge units before transitioning to a more permanent destination?
Not off the top of my head, but
we're working on that right now.
Yeah. I guess we should have that number
right
in a month, maybe. Probably less than a month. But we try to keep it to 3 months. Some participants, kind of like I said earlier, have more significant issues in locating housing due to things like background, right, or where they want to be located in the city. Somebody might be a sex offender and want to live on the north side, right? And so that person might be looking for housing for a while, and then if it goes past 3 months, we'll say we need to start thinking about the west side or the south side because we're not finding units here, right? So I imagine and there's some people who are housed much quicker than that, or in bridge maybe for a month. So I imagine it's around 3 months.
Great.
And Ben, you had several individuals that did not want to go to bridge, correct? They wanted to go directly?
Right. Yeah, so it's also a choice if somebody wants to stay in a shelter or stay on the street. I mean, we've had people who have decided not to do bridge and to stay on the street instead until they got housing. So it's not always bridge.
Great. Client choice.
Yep.
Okay, well, that is the questions that I've been submitted. I think in order to avoid telephonic free-for-all, I want to do a roll call back through our participants on the meeting, give each accountable community of health representative a chance to ask a final question before we end the meeting. So I'll start with Spokane, Better Health Together. do you have any final questions for our team in Chicago? Or for us in the room here?
Thank you so much. This is so helpful.
Okay, great. Cascade Pacific, any further questions?
No further questions. Thank you for answering the chat box questions, though.
Yeah, you're welcome. Great. Thank you. Greater Columbia, Accountable Community of Health. Any final questions for the team? Doesn't look like it. Okay, King County, Healthier Here. Any final questions?
This is Elise from Healthier Here. One final question, maybe when you send out your list of other programs, but do you know of any other programs that operate in cities with a very low vacancy rate and not access to additional Section 8 vouchers, et cetera, where housing is the limiting resource? You don't have to answer that now, but that would just be helpful to get a context of how other large urban areas with high housing costs have implemented this.
This is Susan. Quick question about the CHIRP and the SIT, I think you call them separately. Now that you have more hospitals involved, is the CHIRP a multi-hospital group, or does each hospital have its own CHIRP as it's making referrals in? And then kind of similar question with the SIT, and gets attached to the program versus all the partners involved, how they're involved in that.
You're cutting. Sorry, you go first.
Yeah, go ahead. I was just going to say, your question was broken up a little bit, a little broken up. It was hard to hear. Can you take one more turn at that question?
Yes, sorry about that, and I can type it in. My question is about the structure of both the CHIRP and the SIT with more hospital and partner organizations involved. Does each go have its own CHIRP, or is it one CHIRP for the program? And similar with the SIT, how do you involve all the hospitals and the staff and partners, housing partners, in the staffing of all of this?
Yeah. So each hospital project has its own. The flow is almost exactly alike, but when we get referrals from Rush, that doesn't come from a joint meeting between Rush Hospital and UI Health Hospital. Rush has its own meeting to determine who is referred to the program. So the hospitals are, each project is separate, even though they follow the same model, right? And then in terms of housing providers, so case managers from different housing providers participate in the SIT meetings, depending on kind of grouped by hospital, right? So UI Health has a SIT meeting that happens once a month. Rush has a SIT meeting that happens once a month. Northwestern has a SIT meeting that happens once a month. But they're different. They're different SIT meetings. They're not the same. So basically, the process is the same across hospitals, but the hospitals don't meet together. They're not part of the same process. Does that make sense?
Yes. Thank you very much.
Yeah. Hello?
Nope.
Is everybody still there? I can't really. Okay.
I don't think King County has any more questions, if that's what you're waiting for. I think we're
okay.
Mm-hmm.
Sorry. This is Jeff, and I was on mute, so I would think I'd learned that lesson by now. Wanted to check in with North Central and North Sound ACH, see if you joined us during the presentation. Are you there? And do you have any questions? Okay, I don't think so. Olympic Community of Health. Are you still with us? And do you have any further questions for the team? How about Pierce County, Elevate Health? Any further questions? And Southwest, ACH? Okay, so I'm going to say no further questions at this point. I think my colleagues from RDA have a couple of parting comments. Do you want to talk about that?
Yeah, sure. So this is Katie from RDA. Just want to emphasize the elements that are in the RFP. We're pretty clear about what components are structured in terms of the program process, and then what components are up to the accountable community of health and their partners. So, for example, we say you have to have an assessment tool, but it doesn't necessarily have to be locus. You have to tell us what assessment tool and why. And so we encourage you to learn from the Chicago model, but do remember that if there are elements that are perhaps more useful for your region or already in place in your region, please feel free to propose those, providing a justification and those sorts of things. So yes, definitely take a look at the materials in the RFP to just confirm which components are required and which components you can tailor to your region.
Great. I think that's it. I'll go ahead and put it open one more time to the entire field. Any last questions before we end the meeting? Okay, great, everybody. Thank you so much for your time. And ACH representatives, I will be posting the recording of this go-to meeting on YouTube this afternoon. You'll be getting an email with a link to that video also this afternoon. Thanks for your time. Have a great afternoon.
Thank you, Jeff.
Thanks, Jeff.
Thank you.
Thank you.